Splintered QRS is a term used in the description of ECG in A. Epstein's anomaly, B. Acute myocardial infarction, C. Ventricular septal defect, D. Pericardial effusion. Correct answer A. Epstein's anomaly. A newer terminology for such multiple components of QRS complex is fragmented QRS. Factors enhancing risk of digoxin toxicity. A. Co-administration of verapamil, B. Hypokalemia, C. Hypomagnesemia, D. All of the above. Correct answer D. All of the above. Hypokalemia, which often occurs due to the diuretic therapy which is given along with digoxin for the treatment of heart failure, potentiates the problem of digitoxicity. Correction of hypokalemia is very important in the management of digoxin toxicity. Severe hypomagnesemia can precipitate digoxin-induced cardiac arrhythmia with normal serum digoxin and potassium levels and respond to correction of hypomagnesemia. Important drugs which can increase the levels of digoxin are quinidine, verapamil, amiodarone and dronedarone. The dose of digoxin should be halved with concomitant use of verapamil, amiodarone or dronedarone. Type of ASD seen in this echo: A. Sinus venosus, B. Secundum, C. Primum, D. None of these. Correct answer B. Secundum. There is a good rim of septal tissue between the atrial septal defect and the atrioventricular valves, suggesting secundum ASD. In sinus venosus ASD, the superior rim will not be there. This chest X-ray is suggestive of A. Primary pulmonary hypertension, B. Atrial septal defect with pulmonary hypertension, C. Ventricular septal defect with pulmonary hypertension, D. Idiopathic dilatation of pulmonary artery. Correct answer B. Atrial septal defect with pulmonary hypertension. End-on view of dilated pulmonary artery branches suggest increased pulmonary blood flow as the cause of pulmonary hypertension. Right atrial enlargement is not seen in ventricular septal defect with pulmonary hypertension. Upturned right ventricular type of apex is also seen. Giant T-wave inversion may be seen in all except A. After a cardiac arrest, B. Subarachnoid hemorrhage, C. Hyperkalemia, D. Takotsubo cardiomyopathy. Correct answer C. Hyperkalemia. Giant T-wave inversion can be broad and deep or just deep T inversions. A depth of T-wave of 10 mm or above is generally considered as deep T inversion. Giant T-wave inversions with depth of 35 mm have also been described in literature. Deep T inversions without gross increase in width can occur in ischemia and hypertrophic cardiomyopathy. In a study involving 864 patients with hypertrophic cardiomyopathy, 15% had giant T-wave inversion. While giant T-wave inversions occurred in about one-third of patients with apical hypertrophic cardiomyopathy, it was seen in only 6.2% of those with asymmetric septal hypertrophy and one-fourth of those with mixed pattern of hypertrophy. But there was no significant correlation between the apical myocardial thickness and the amplitude of T-wave inversion. This ECG shows A. Anterior wall infarction, B. Anterior wall infarction with right bundle branch block, C. Anterior wall infarction with RBBB and atrial fibrillation, D. None of the above. Correct answer C. Anterior wall infarction with RBBB and atrial fibrillation. The ECG has an irregular baseline with no regular P waves indicating atrial fibrillation. RSR prime pattern with T-wave inversion is visible in the anterior chest leads. It may be noted that R waves are tiny while the R prime waves are prominent and slurred. The tiny R waves, poor progression of R waves in anterior leads, indicate anterior wall myocardial infarction as they are equivalent to Q waves. Slurred R prime waves indicate the presence of a right ventricular conduction delay in the form of right bundle branch block. Symmetric arrowhead inverted T waves also indicate myocardial ischemia. Wide QRS tachycardia at 300 per minute can occur with A. Atrial fibrillation with Wolff-Parkinson-White syndrome, B. Supraventricular tachycardia with aberrancy in the very young, C. Atrial flutter with 1:1 conduction, D. All of the above. Correct answer D. All of the above. In AF with WPW syndrome, rate is fast due to conduction through accessory pathway with low refractory period as well as through AV nodal pathway. Polymorphic ventricular tachycardia is another cause of wide QRS tachycardia at 300 per minute. Swiss cheese VSD is A. Subpulmonic VSD, B. Perimembranous VSD, C. Multiple muscular VSD, D. None of the above. Correct answer C. Multiple muscular VSD. Multiple muscular ventricular septal defects are also called Swiss cheese VSD. Swiss cheese VSDs are associated with left axis deviation on ECG. They are difficult to close surgically. It is difficult to locate the openings of the VSD from the right ventricular side. Some may have multiple right ventricular openings for a single left ventricular orifice. Cone procedure is used for A. Detransposition of great arteries, B. Fallow's tetralogy, C. Epstein's anomaly of tricuspid valve, D. None of the above. Correct answer C. Epstein's anomaly of tricuspid valve. Cone procedure for Epstein's anomaly of tricuspid valve constructs a funnel-like valve using the native valve leaflets. This avoids the problems associated with artificial valves, including bioprosthetic valves, especially in children. In one study, cone procedure group had 85% reduction in tricuspid regurgitation compared to 56% in the conventional group at discharge from hospital. The cone procedure involves detachment of tricuspid leaflets, division of chordae, plication of the tricuspid annulus, rotation of leaflets, and final reinsertion of the leaflets in the modified tricuspid valve annulus. Stent creep is A. Creeping of neointimal proliferation into bare metal stent, B. Telescoping of stent struts due to concertina effect, C. Seen in Hancock bioprocesses and is due to inward bending of the stent struts, D. None of the above. Correct answer C. Seen in Hancock bioprocesses and is due to inward bending of the stent struts. It is not obvious on echocardiographic imaging but increases the transvalvular gradient as measured by Doppler echocardiography. Stent creep tends to increase with time after implantation. It is due to an ultrastructural deformity of polypropylene used in the valve stent. To reduce risk of nephrogenic systemic sclerosis after MRI, A. Limit the dose of gadolinium-based contrast agent to less than 0.1 millimole per kg body weight. B. Dialyze them quickly after contrast administration. C. Delay contrast administration till recovery of renal function in those with acute renal failure. D. All of the above. Correct answer D. All of the above. In addition to these, avoiding non-linear gadolinium-based contrast agents in those with renal failure, more so when there are pro-inflammatory conditions associated, is also useful. Standard surgical treatment for chronic thromboembolic pulmonary hypertension: A. Pulmonary thromboendarterectomy, B. Single lung transplantation, C. Pulmonary banding, D. None of the above. Correct answer A. Pulmonary thromboendarterectomy. In selected patients, pulmonary thromboendarterectomy is curative, but residual pulmonary hypertension after surgery is common. Those with residual pulmonary hypertension need long-term follow-up and vasodilator therapy with sildenafil or ambrisentan. Pulmonary thromboendarterectomy is a prolonged surgical procedure and can be undertaken only in specialized centers. Following are true of Anderson-Tawil syndrome: A. Prominent U waves, B. Periodic paralysis, C. Facial dysmorphism, D. All of the above. Correct answer D. All of the above. In addition to these, life-threatening ventricular arrhythmias are the hallmark of Anderson-Tawil syndrome. It is associated with KCNJ2 potassium channel mutation. This channel encodes for the alpha subunit of KIR 2.1 related to inward rectifier potassium current IK1. Mutation positive cases, which constitute about 60%, are designated type 1 and the rest as type 2. Prosthetic valve seen on this X-ray is A. Starr-Edwards prosthetic aortic valve, B. Starr-Edwards prosthetic mitral valve, C. Starr-Edwards prosthetic pulmonary valve, D. Starr-Edwards prosthetic tricuspid valve. Correct answer B. Starr-Edwards prosthetic mitral valve. Prosthetic mitral valve is situated below the line joining the pulmonary bay and right cardiophrenic angle, while the aortic valve is situated above the line. Starr-Edwards mitral prosthetic valve has 4 struts, while the aortic valve has only 3 struts. Struts of aortic prosthetic valve point upwards and to the right, while the struts of the mitral valve points downwards and to the left. ECG pattern is diagnostic of A. Right bundle branch block, B. anteval myocardial infarction, C. Brugada syndrome, D. early repolarization syndrome. Correct answer C. Brugada syndrome. In true right bundle branch block, ST segment is depressed in anterior leads. In myocardial infarction, when the T wave is inverted, the ST segment is more rounded, though elevated. In early repolarization, the ST segment is concave upwards. Left anterior hemiblock is characterized by all of the following except A. Left axis deviation, B. RS complexes in 2-3 AVF, C. No significant QRS widening, D. QR complexes in 2-3 AVF. Correct answer D. QR complexes in 2-3 AVF. QR complexes in 2-3 AVF are seen in left posterior hemiblock. QR complexes are noted in 1 and AVL in left anterior hemiblock. ECG finding is suggestive of A. Myocardial infarction, B. Dilated cardiomyopathy, C. Pericardial effusion, D. None of the above. Correct answer C. Pericardial effusion. ECG shows electrical alternance in pericardial effusion. Electrical alternance in pericardial effusion is due to swinging of the heart within the fluid-filled pericardial cavity. QRS amplitude is larger when the heart is in the direction of the ECG lead axis and shorter when the heart is away. Dreaded arrhythmia in association with WPW syndrome is A. Orthodromic AVRT, B. Antidromic AVRT, C. Atrial fibrillation, D. Atrial flutter. Correct answer C. Atrial fibrillation. Orthodromic AVRT is the commonest arrhythmia in WPW syndrome, while atrial flutter is not an arrhythmia usually associated with WPW syndrome. In orthodromic AVRT, the signal passes down the normal atrioventricular conduction system and back from the ventricle to the atrium by the accessory pathway. Hence, the QRS is narrow. The opposite occurs in antidromic AVRT, causing the QRS to be wide. In atrial fibrillation, the high rates are conducted down simultaneously through both the normal AV node as well as through the accessory pathway, so that the ventricular rates become very high. Normal AV node has the property of decreasing conduction when it receives large number of atrial signals. But accessory pathway in fact conducts more impulses at faster rates. The dangerously high ventricular rates can degenerate into ventricular fibrillation. Hence, atrial fibrillation with WPW syndrome presents as a fast, irregular wide QRS tachycardia and needs immediate electrical cardioversion to prevent sudden deterioration. Diagnosis based on the echocardiogram. A. Epstein's anomaly of tricuspid valve, B. Idiopathic dilatation of right atrium, C. Endomyocardial fibrosis, D. None of the above. Correct answer C. Endomyocardial fibrosis. Endomyocardial fibrosis is a type of restrictive cardiomyopathy. It is characterized by fibrosis and obliteration of the ventricular cavity, predominantly involving the right ventricle. Such gross right atrial enlargement may also be noted in Epstein's anomaly of tricuspid valve, but the fibrosis at right ventricular apex is not seen. In Epstein's anomaly, there is distal displacement of the septal and posterior leaflets of tricuspid valve. Typical maximum voltage of biphasic defibrillator shock: A 110 volts, B 220 volts, C 440 volts, D 2200 volts. Correct answer D 2200 volts. Typical biphasic defibrillator shock voltage can be 2200 volts and monophasic defibrillator shock 5000 volts at maximum output. Most important factor affecting survival after CABG: A. Type of graft used, B. Left ventricular function, C. Number of grafts used, D. Severity of native vessel disease. Correct answer B. Left ventricular function. Left ventricular function is the most important factor determining survival after CABG. Arterial grafts have a better long-term patency and improves symptom-free survival. Guideline recommended level of physical activity for reducing cardiovascular risk: A. 50 met minutes per week, B. 100 met minutes per week, C. 500 met minutes per week, D. 5000 met minutes per week. Correct answer C. 500 met minutes per week. It is well known that physical activity is a modifiable risk factor for coronary artery disease. 500 met minutes per week would correspond to 150 minutes per week of moderate aerobic physical activity. 1 met is the basal metabolic oxygen requirement. It will correspond to an oxygen consumption of 3.5 ml oxygen per kilogram body weight per minute. Sleeping will give a met value of 0.9 and running at 22.5 km per hour will give a met value of 23. Met minutes is obtained by multiplying the met value of the activity by the minutes for which the activity is sustained. For example, having a 5 met activity for 100 minutes will give a 500 met minute level. Jogging will give a met level of 7, while walking at 3 miles per hour gives a met level of 3.3. Sitting and watching television has a met level of 1.0. Arterial embolectomy is done using A. Microcatheter, B. Cobra catheter, C. Fogarty catheter, D. Cournan catheter. Correct answer C. Fogarty catheter. Cournan catheter is an end-hole catheter used for right heart studies. Cobra catheter with tip shaped like a cobra hood is used for renal angiography. Microcatheters are used for entering small distal vessels and are introduced through a standard catheter. Fogarty catheter used for peripheral arterial embolectomy is introduced anterogradely across the embolus. The distal balloon is inflated and the catheter withdrawn to bring out the thrombus, usually through an arteriotomy. Conventionally, general surgeons have been doing arterial embolectomy, often in the femoral and popliteal arteries. 60/60 sign has been described in A. Acute myocardial infarction, B. Aortic dissection, C. Acute pulmonary embolism, D. None of the above. Correct answer C. Acute pulmonary embolism. 60/60 sign in acute pulmonary embolism is a pattern detected by Doppler echocardiography indicating a disturbed right ventricular ejection pattern. The sign has two components. One, tricuspid regurgitation jet of less than 60 millimeters of mercury, TR velocity less than 3.9 meters per second, and 2, pulmonary flow acceleration time of less than 60 milliseconds. It may be noted that TR gradient should be above 30 millimeters of mercury to indicate pulmonary hypertension due to pulmonary embolism. High TR gradient may indicate chronic thromboembolic pulmonary hypertension, especially in the presence of right ventricular free wall hypertrophy, suggesting long-standing pulmonary hypertension. Identify the cardiac chamber with filling defect marked by red arrow in the cardiac CT. A. Right atrium, B. Left atrium, C. Right ventricle, D. Left ventricle. Correct answer B. Left atrium. The chamber with filling defect marked by red arrow is just anterior to the spine and is hence the left atrium. Negative shadow is due to the thrombus in the left atrium. Measures to prevent spinal cord ischemia in thoracic endovascular repair of aortic aneurysm. A. Avoiding blockage of left subclavian. B. Surgical graft to left subclavian before TEVAR. C. Pre-procedure drainage of CSF. D. All of the above. Correct answer D. All of the above. Spinal cord ischemia manifesting as paraplegia is one of the important complications of TEVAR. Avoiding blockage of left subclavian, which gives branches which eventually supply the spinal cord, is a preventive option in elective setting. In cases in which left subclavian needs to be overstented, a hybrid procedure with surgical graft to the vessel likely to be blocked being placed before TEVAR is an option. Pre-procedure drainage of cerebrospinal fluid can be useful as it has been proven useful in aortic surgery for protection of spinal cord. CSF drainage is an immediate option for reversal of paraplegia if it does occur, unfortunately. Other option is to raise the blood pressure with mean around 90 millimeters of mercury. Episodes of hypotension should be prevented as far as possible to prevent spinal cord ischemia. Typical arrhythmia seen in holiday heart syndrome. A. Ventricular tachycardia. B. Ectopic atrial tachycardia. C. Atrial fibrillation. D. None of the above. Correct answer C. Atrial fibrillation. Holiday heart syndrome is the name given to atrial fibrillation which occurs after binge drinking. The original description was in 1978 by Ettinger and colleagues. That study reported 32 arrhythmic episodes in 24 patients. There was spontaneous recovery with abstinence from alcohol. Carotid femoral pulse wave velocity increases with A. Age, B. Hypertension, C. Renal failure, D. All of the above. Correct answer D. All of the above. Carotid to femoral pulse wave velocity is taken as the gold standard for measuring aortic stiffness. Pulse wave velocity increases as the arterial wall stiffness increases with age. Other conditions which can increase the arterial wall stiffness are hypertension, diabetes mellitus, and renal failure. The pulse wave velocity is measured from the propagation time for the pulse wave to travel from the carotid to the femoral artery, both being accessible for external measurements. Arterial tonometer can be used to record the waveform, and the propagation time is measured from the foot of the carotid waveform to that of the femoral waveform with reference to the electrocardiogram. In this case, the measurement need not be simultaneous. Alternatively, simultaneous measurement from both carotid and femoral arteries using mechanotransducers can determine the propagation velocity from the peak upstrokes of both tracings. The structure marked with red arrow in the echo image: A. Central venous catheter, B. Chiari network, C. Pacemaker lead, D. None of the above. Correct answer C. Pacemaker lead. Chiari network is seen only in the right atrium. The structure marked is extending across the tricuspid valve into the right ventricle. Central venous catheter tip is usually placed in the superior vena cava. Occasionally, the tip of a central venous catheter placed at bedside without fluoroscopic guidance can be in the right atrium, but it seldom crosses the tricuspid valve into the right ventricle. An implantable defibrillator lead also traverses the tricuspid valve into the right ventricle. The defibrillator lead is much thicker due to the presence of shocking coil in the right ventricle. Wien-Kessel effect is noted in A. Aorta, B. Coronary arteries, C. Cerebral arteries, D. None of the above. Correct answer A. Aorta. The term Wien-Kessel effect is used in the setting of large elastic arteries like aorta. The original term Wien-Kessel means air chamber in German language. It was an air chamber used in fire engines in the 18th century to maintain continuous delivery of water for firefighting. In the case of aorta, the aortic elasticity causes expansion and temporary storage of blood in systole so that more blood enters the aorta than what leaves it in systole. This buffer stock of blood is released during diastole to maintain organ perfusion. The Wien-Kessel effect makes aorta function as a second pump in diastole. This diastolic flow is quite important in the case of coronary perfusion, as most of the coronary perfusion is diastolic. As the elasticity decreases with aging, this buffer effect is reduced, leading to an increase in arterial pulse pressure and systolic pressure. Which of the following is not a radiological sign of left atrial enlargement? A. Double atrial shadow, B. Knuckle sign, C. Elevated left bronchus, D. Prominent left atrial appendage. Correct answer B. Knuckle sign. Knuckle sign is the abrupt cutoff of a pulmonary artery branch due to pulmonary embolism. Double atrial shadow is the visible left atrial shadow within the cardiac outline near the right heart border. Prominent left atrial appendage is seen as a bulge along the left upper border just below the pulmonary artery segment. The left atrial appendage enlarges along with the body of the left atrium. It will not be seen if the left atrial appendage has been removed earlier, as in case of closed mitral valvotomy, which is seldom performed currently. Elevated left bronchus is seen as a radiolucent outline within the cardiac outline, as the left bronchus is lifted up by an enlarged left atrium.